This recording will go over low back pain. The lumbosacral, lower back, and cervical neck vertebrae are most commonly affected because these are the areas where the vertebral column are the most flexible. So where I'm most bendy in terms of my spine and neck is going to be where I'm going to be most likely to have pain and injury. Under pathophysiological review here, acute pain is caused by muscle strain or spasm, ligament sprain, disc degeneration, or herniation of the center of the disc, the nucleus pulposus. The herniated nucleus pulposus and the lumbosacral area can press against the adjacent spinal nerve, usually the sciatic nerve, causing burning or stabbing pain down into the leg or foot, which in some cases can be very severe. So most people have heard about a herniated disc, and this is what we're talking about. The disc is actually pressing against the spinal cord and the nerve root, causing issues including pain and paresthesias, could be weakness, a whole lot of complications for the patient. So in addition to acute or persistent pain, there can also be muscle spasms, numbness, tingling, and the affected leg because spinal nerves have both motor and sensory fibers. The herniated discs may press on the spinal cord itself, causing leg weakness. Bowel and bladder incontinence or retention can also occur. Back pain, another cause, could be spinal stenosis, which is a narrowing of the spinal canal, nerve root canals, or intervertebral foramina, typically seen in people who are a little bit older than 50. Acute back pain usually results from injury or trauma, such as during falls, motor vehicle accidents, when lifting a heavy object. The mechanism of injury is repetitive flexion and or extension and hyperextension, hyperreflexion with or without rotation. Obesity is another cause of problems with the back, smoking, as well as congenital spinal conditions, so born with something wrong with the spinal cord. Within your textbook, you have a box that lists some health promotion and maintenance tips. They include safe manual handling practices, paying attention to bending, lifting, and sitting, asking for assistance if needed, keeping up with regular exercise programs, avoiding high-heeled shoes, using good posture when sitting, standing, and walking, avoiding prolonged sitting or standing, keeping weight within 10% of the ideal body weight, ensuring adequate calcium intake and vitamin D supplements, and to stop smoking. Ergonomics is an applied science in which the workplace is designed to increase worker comfort while increasing efficiency and productivity. A big thing in healthcare would be the equipment that we use to move patients, right, in order to help prevent injury to ourselves. So using lifts, sit to stand, sort of lift assist, doing the things we need to do in order to save our back. Raising the bed could be something as well in nursing. Having the bed at a comfortable working level so that you're not straining your back continuously. So in terms of what are you going to see with the patient with lower back pain? It's pain. The patient's primary concern is going to be pain. So we want to do a thorough, complete pain assessment, ask about anything that happened before the pain, is there anything that relieves the pain, assess their back for vertebral alignment, any tenderness, looking at the surrounding anatomy, lower extremities for any injuries, asking whether they have any abnormal sensations, paresthesia, tingling, numbness, anything like that. Do they have any problems with sensory perception? Can they feel soft and sharp touch? Ask about urinary or fecal continence and any problems with constipation. If the sciatic nerve is compressed, severe pain usually occurs when the patient's leg is held straight and lifted up. Want to ask about any weakness, ankle, foot, or leg weakness. Also assess the patient's muscle tone and strength. Finally, the pain can be debilitating, especially if it's been going on for a while, so you want to assess for depression and any suicidal ideation. In terms of imaging, major things we're going to see is an x-ray. Usually it'll show general arthritis and any changes in alignment. CT scan. More information could be gathered from an MRI. It's possible that they do a bone scan. Electrodiagnostic testing such as EMGs and nerve conduction studies can help to distinguish motor neuron diseases from peripheral neuropathy and radiculopathy. Those tests are especially useful in chronic diseases of the spinal cord and associated nerves. Take action. So what are we going to do for the patient with low back pain? Management of low back pain varies with the severity and how chronic the problem is. Some patients need only brief treatment regimen of at-home exercise or PT to manage pain. Other people end up having surgery, just, they can't get the pain under control. So, non-surgical management, what are we doing? For the patients with acute, non-specific lower back pain, non-pharmacological measures are often the first line of treatment. Rest, a short period of back rest with heat or ice can be prescribed. Heat has been shown to offer some short-term benefits. Physical therapy can help strengthening surrounding muscles, and the therapist can educate the patient on preventing further injury. The patient should begin stretching exercise and resume normal activity as soon as possible. Aerobic exercise can be supportive when the patient is able to do it. Most patients find that they need to change positions frequently. The Williams position is typically more comfortable and therapeutic for patients with acute lower back pain from a bulging or herniated disc. The Williams position has the patient lying in semi-Fowler's position with a pillow under the knees to keep them flexed or sitting in a reclining chair. This position relaxes the muscles of the lower back and helps to relieve any pressure on the spinal nerve root. Patients with chronic lower back pain may also benefit from complementary or integrative therapies such as stress reduction, mindfulness, progressive muscle relaxation, yoga. Cognitive behavioral therapy, in addition to PT, has strong evidence to support its use in patients whose pain continues beyond 12 months. If meds are needed, non-selective NSAIDs are helpful. Opioids may be used sparingly, but NSAIDs are going to be preferred over the opioids. Topical capsicum can also be used to provide good pain relief on a short-term basis. Ziconotide is a potent analgesic sometimes used for patients with severe persistent pain. Muscle spasms can be a problem, and for that, patients would take muscle relaxants. Commonly used meds for muscle spasms include diazepam, cyclobenzaprine, and tizanidine. Remember that centrally acting muscle relaxants can cause sedation, dizziness, and lightheadedness. Many muscle relaxants also have anticholinergic side effects, including dry mouth, urinary retention, blurred vision, constipation, and tachycardia. We worry about falls with our patients, especially older adults. We don't want them driving. We don't want them drinking alcohol or taking any other meds that will depress the CNS. Physical therapists will work with the patient to develop an individualized exercise program. Weight reduction can also be helpful for a patient with persistent low back pain by decreasing the strain on the vertebrae caused by excessive weight. Surgery. Surgery can be performed if conservative measures fail to relieve persistent back pain or if neurologic deficits continue to progress. Pre-op care would involve teaching the patient what to expect post-op, including techniques for getting in and out of bed, turning or moving in bed, immediately reporting any new motor or sensory changes, and then home care activity or restrictions. In terms of the surgical procedures themselves, we're going to focus on the three listed here: discectomy, laminectomy, and spinal fusion. The textbook talks about whether it's minimally invasive or open procedure, And you guys understand the basics of that. Obviously, a minimally invasive is going to have less complications, a shorter recovery time. An open procedure would be more involved, greater risk for complications, a longer recovery time. You want to recognize what these three names stand for. Discectomy, ectomy being removal, is removal of the herniated disc. Laminectomy includes removal of part of the laminae and facet joints to obtain access to the disc space. Finally, a spinal fusion, just like it sounds like you're fusing two things together, connects two or more vertebrae to stabilize the spine and release compression on the spinal nerves. Post-op care then, what are we worried about post-op for these patients? We're worried about preventing and assessing for any complications. Want to be assessing assessing vital signs frequently, as well as neural assessments, including level of consciousness. Major complications for an open traditional lumbar spinal surgery include nerve injuries, discitis or disc inflammation, dural tears, which are tears of the covering of the spinal cord, worried about cerebrospinal fluid leakage as well. Check the patient's ability to void after a catheter has been removed. Acute back pain in a flat position in bed can make voiding difficult, especially for men. Inability to void could indicate damage to the sacral spinal nerve, so it's something we want to be assessing and reporting if the patient can't void. Correct turning is important. We don't want to use any overhead trapezes. Want to tell the patient to log roll every 2 hours. Remember, that's moving as one unit, no twisting, keeping the spine straight. The patient should sit in a straight back chair with feet resting comfortably on the floor. And as with all surgical patients, preventing atelectasis and hypostatic pneumonia with deep breathing and incentive spirometry is advised. After conventional open lumbar surgery, the patient may have activity restrictions up to 6 weeks that include limiting daily stair climbing, restricted or limited driving, not lifting objects heavier than 5 pounds, avoiding pushing and pulling activities including dog walking, vacuuming, avoiding bending and twisting at the waist, and taking daily walks. The patient may have a back orthotic device that has to be worn for up to 6 weeks, so we want to make sure they understand the importance of the brace and how to use it. Spinal cord stimulation is an invasive technique that provides persistent pain relief by applying an electrical field over the spinal cord. If a trial percutaneous spinal cord stimulation is successful, electrodes are surgically placed internally in the epidural space and connected to an external or implanted programmable generator. The patient's then taught to program and adjust the device to maximize comfort. For patients who have spinal cord stimulator implanted in the epidural space, assess neural status below the level of insertion frequently and monitor for any changes in sensory, motor, or muscle strength. Ensure that the patient can void without difficulty as well. Finally, your textbook, we talked about some complications, but your textbook does have a table for complications associated with open traditional lumbar spinal surgery. The first one listed is cerebrospinal fluid leakage. So anytime there's clear fluid leaking, we'd want to test it. And if it's positive for the halo, positive for glucose, that would tell us it is indeed cerebrospinal fluid. Other things we're watching for: fluid volume deficit, acute urinary retention, paralytic ileus, fat embolism syndrome, persistent or progressive lumbar radiculopathy, as well as infection.